Chapter 15, the urinary system. The urinary system is very important in that it filters waste from the blood and helps to regulate your water, electrolyte, and acid-base balances in the body. It does this via the kidneys that filter blood and nephrons and secrete or reabsorb electrolytes under the direction of hormones. And the kidneys are directly involved in maintaining proper blood pressure, which we've talked about a little bit in past lectures, which is essential for delivering oxygen and nutrients to the tissues and for proper filtration of blood by the kidneys themselves. The urinary system. The urinary system is just the system primarily responsible for water, electrolyte, and acid-base balance and the removal of nitrogen-containing waste from the blood. You can see in the image here on the right, the image A is an example of female anatomy, but you can kind of see where the kidney placement is. And then down below that, you can see in relationship to the ribs where the kidneys are. The urinary system includes the kidneys, the ureters, the urinary bladder, and the urethra, all which we'll talk about on coming slides. The kidneys are primarily charged with maintaining the purity and constancy of your internal fluids, helping your body remain in homeostasis. So the major responsibility is eliminating nitrogenous, nitrogen-containing wastes, toxins, and drugs from the body. By producing the enzyme renin, they help to regulate your blood pressure. The hormone erythropoietin, which should sound familiar to you, is also released from the kidneys and stimulates red blood cell production in the bone marrow. And then kidney cells also convert vitamin D produced in the skin into its active usable form. So many important functions of the kidneys. So in this image, you can see the internal anatomy of the kidney and also the order of blood flow from the heart through the kidneys and back out. So the kidneys, as we saw in that third slide, are located in the superior lumbar region, so about T12 to L3, so some protection from the lower rib cage. An adult kidney is about 12 centimeters long by 6 centimeters wide by 3 centimeters thick, or about the size of a bar of soap. Several structures, including ureters, renal blood vessels, and nerves, enter and exit the kidney at the hilum. So the lateral part of the kidney, so the part closest to the lateral part of your body, is convex. And then medially, there's a small indentation. You can see in the photos here that it's a kidney bean shape, and the small indentation is where all of those structures exit and enter. And then sitting atop each kidney is your adrenal gland, which is part of the endocrine system and is a separate organ. Kidney has 3 protective layers. So deep to superficial, they are as follows. A transparent fibrous capsule encloses each kidney and gives it a glistening appearance. A fatty mass called the perirenal fat capsule surrounds each kidney and acts as like a cushion or a protective layer. And then the renal fascia is the most superficial layer made of dense fibrous connective tissue, and it anchors the kidney and adrenal gland to surrounding structures. So one of the homeostatic imbalances here is hydronephrosis. So this is what happens, So the fat surrounding the kidneys is important in holding them in their normal position. If the amount of fatty tissue dwindles, as might happen with rapid weight loss, the kidneys may drop to a lower position in a condition called ptosis. Ptosis creates problems if the ureters, which drain from the kidneys, become kinked. When this happens, urine that can no longer pass through the ureters backs up and exerts pressure on the kidney tissue. So it's just like kinking a hose. There's a lot of pressure building up behind the kink. This condition is called hydronephrosis and can severely damage the kidney. Nephrons are the structural and functional units of the kidney and are responsible for the formation of urine. Each kidney contains over 1 million of these tiny filters. In addition, there are thousands of collecting ducts, each of which collects fluid from several nephrons and conveys it to the renal pelvis, and the figure here shows the anatomy and relative position of nephrons and the collecting ducts in each kidney. So A is a wedge-shaped section of kidney tissue indicating the position of the nephrons in the kidney. B is the detailed anatomy of a nephron and its associated blood supply. Part of the distal convoluted tubule and afferent arteriole have been sectioned to reveal the location of the juxtaglomerular apparatus. C, we're looking at a diagrammatic view of the relationship of the visceral layer of the glomerular capsule to the glomerular capillaries. And D, a scanning electron micrograph of podocytes clinging to the glomerular capillaries. So each nephron has two main structures, a renal corpuscle and a renal tubule. So each corpuscle consists of a glomerulus. Which is a knot of coiled capillaries in the kidneys and forms filtrate, which we'll talk about here in a couple slides. The portion of the renal corpuscle is called a glomerular capsule or Bowman's capsule. The inner visceral layer of the capsule is made up of highly modified octopus-like cells called podocytes, which is what you're seeing again in D. Podocytes have long branching extensions called foot processes that intertwine with one another and cling to the glomerulus. Yeah, having trouble with that word. Openings called filtration slits between these processes allow the podocytes to form a porous or leaky membrane around the glomerulus, ideal for filtration. The renal tubule, which makes up the rest of the nephron, is about 3 centimeters long. As it extends from the capsule, it coils and twists before forming a hairpin loop, then again becomes coiled and twisted before entering a collecting duct. These different regions of the tubule have specific names. In order from the glomerular capsule, they are proximal convoluted tubule, the nephron loop, the loop of Henle, and the distal convoluted tubule. The surfaces of the tubule cells exposed to the filtrate and the proximal convoluted tubules are covered in dense microvilli, which increase their surface area tremendously. Microvilli also occur in the tubule cells and other parts of the tubule, but in much reduced numbers. Most nephrons are cortical nephrons because they are located almost entirely within the cortex. In a few cases, the nephrons are called juxtamedullary nephrons because they are situated close to the cortex medulla junction, and their nephron loops dip deep into the medulla. The collecting ducts, each of which receiving urine from many nephrons, run downward through the medullary pyramids, give the pyramids a striped appearance. They deliver the final urine product into the calyces and the renal pelvis. Urine formation is the result of 3 processes: glomerular filtration, tubular reabsorption, and tubular secretion. So glomerular filtration, as you can see on the right, is when water and solutes smaller than proteins are forced through the capillary walls and pores of glomerular capsule and into the renal tubule. Then tubular reabsorption occurs. Water and glucose, amino acids, and needed ions are transported out of the filtrate into the tubule cells and then enter the capillary blood. And then 3, tubular secretion. Hydrogen ions, potassium ions, creatinine, and drugs are removed from the peritubular blood and secreted by the tubule cells into the filtrate. And I'll go more in depth on each of those here shortly. Some of the homeostatic imbalances. Oliguria, which is abnormally low urine output, it's between 100 and 400 mLs a day, and anuria is if it is less than 100 mLs a day, so somebody's just not peeing for whatever reason. Low urinary output usually indicates that glomerular blood pressure is too low to cause filtration, but anuria may result from transfusion reactions and acute inflammation or from crush injuries to the kidneys. Glomerular filtration. Can you tell I've been practicing that word? So we know the glomerulus acts as a filter. So glomerular filtration is a non-selective passive process in which fluid passes from the blood into the glomerular capsule, part of the renal tubule. So once in the capsule, the fluid is called filtrate, which is essentially blood plasma without blood proteins. Both proteins and blood cells are normally too large to pass through the filtration membrane, and when either of these appears in the urine, there's usually a problem with the glomerular filters. As long as the systemic blood pressure is normal, filtrate will be formed. If arterial blood pressure drops too low, glomerular pressure becomes inadequate to force substances out of the blood into the tubules, and filtrate formation stops. So that's kind of what we were talking about when we were talking about oliguria and anuria. And then that second process, tubular reabsorption. So besides waste and excess ions that must be removed from the blood, the filtrate contains many useful substances, things we need like water, glucose, amino acids, and ions, which must be reclaimed from the filtrate and returned to the blood. So tubular reabsorption begins as soon as the filtrate enters the proximal convoluted tubule, and the tubule cells are transporters taking up the needed substances from the filtrate, then passing them out their posterior aspect into the extracellular space, from which they are absorbed into peritubular capillary blood. Some reabsorption is done passively. For example, water passes by osmosis, but reabsorption of most substances depends on active transport processes, which use membrane carriers, require ATP, and are very selective. There's an abundance of carriers for substances that need to be retained, and few to no carriers for substances that have no use in our body. Needed substances, things like glucose and amino acids, are usually entirely removed from the filtrate, and most reabsorption occurs in the proximal convoluted tubules, but the distal convoluted tubule and then collecting ducts are also active. And then tubular secretion. So it's essentially tubular reabsorption reversed. Some substances, such as hydrogen and potassium ions, are in creatinine, also move from the blood to the peritubular capillaries from the tubule cells or from the tubular cells themselves into the filtrate to be eliminated in urine. This process seems to be important in getting rid of substances not already in the filtrate, such as certain drugs, excess potassium ions, or as an additional means for controlling blood pH. Nitrogenous waste, so nitrogen-containing waste. They're poorly reabsorbed, if at all, so tubular cells have few membrane carriers to reabsorb these substances because we do not need them. They tend to remain in the filtrate and are found in high concentrations in urine excreted from the body. Various ions are reabsorbed or allowed to go out into the urine according to what is needed at that particular time to maintain proper pH and electrolyte composition of the blood. Common nitrogenous wastes include urea, which is formed by the liver as an end product of protein breakdown when amino acids are used for energy. Uric acid, which is released from nucleic acids that have been metabolized, and creatinine, which is associated with creatine metabolism in muscle tissue. Let's talk about some of the characteristics of urine. So the kidneys filter some 150 to 180 liters of blood plasma through their glomeruli into the tubules, which process the filtrate by taking substance out of it, reabsorption, and adding substance to it, secretion. In the same 24 hours, only about 1 to 1.8 liters of urine are produced. Therefore, urine and filtrate are quite different. Filtrate contains everything that blood plasma does except for proteins, but by the time it reaches collecting ducts, the filtrate has lost most of its water and just about all of its nutrients and necessary ions. What remains is urine, which contains nitrogenous waste and unneeded excess substances. Assuming we are healthy, our kidneys can keep our blood composition fairly constant despite wide variations in diet and cell activity. So freshly voided urine is generally clear and pale to deep yellow. The normal yellow color is due to urochrome, which is a pigment that results from the body's destruction of hemoglobin. The more solutes that are in the urine, the deeper yellow its color. Dilute urine is pale, straw color. At times, urine may be a color other than yellow. This can be the result of eating certain foods, things like beets, or the presence of bile or blood in the urine, which would be abnormal. When formed, urine is sterile and its odor is slightly aromatic. If you allow urine to stand, it takes on an ammonia odor, which is caused by the action of bacteria on the urine solutes. Some drugs and vegetables like asparagus and some diseases like diabetes mellitus will give it, will alter that usual odor of urine. Urine pH is usually slightly acidic, around 6, but changes in body metabolism in certain foods may cause it to be more acidic or more basic. For example, a diet high with large amounts of protein, eggs, and cheese, and whole wheat products causes urine to be quite acidic. Conversely, a vegetarian diet makes urine quite alkaline as the kidneys excrete excess bases. Bacterial infection of the urinary tract may also cause urine to be alkaline. Because urine is water plus solutes, urine is denser or weighs more than distilled water. Specific gravity is how much heavier urine is than distilled water. So the specific gravity of pure water is 1.0, and the specific gravity of urine usually ranges from 1.001 to 1.035. And this would be dilute to concentrated urine, respectively. Urine is generally dilute or has low specific gravity when a person drinks excessive fluids, uses diuretics, or has chronic renal failure. In conditions that produce concentrated urine with high specific gravity includes inadequate fluid intake, fever, and kidney inflammation called pyelonephritis. Solutes usually found in the urine include sodium ions and potassium ions, urea, uric acid, creatinine, ammonia, bicarbonate ions, and various other ions depending on blood composition. With certain diseases, urine composition can change dramatically, and the presence of abnormal substances in the urine is often helpful in diagnosing a problem. This is why a routine urinalysis should always be part of a physical examination. And here are some of the substances not usually found in urine. We have glucose, which is called glycosuria. Non-pathological reason could be just an excessive intake of sugary foods, and a pathological reason that you would have glucose in the urine would be diabetes mellitus. Protein in the urine, proteinuria, also called albuminuria. Non-pathological reason would be physical exertion or pregnancy. Pathological would be glomerulonephritis or hypertension. Pus, so this is white blood cells and bacteria, is called biuria. Usually this is because of urinary tract infection. Red blood cells would be hematuria, so blood in the urine. Bleeding in the urinary tract due to trauma, kidney stones, or infection. Hemoglobin, hemoglobinuria. Various reasons this could happen would be transfusion reaction or hemolytic anemia. And then bile pigment, bilirubinuria. And the reason why this would happen would be hepatitis, liver disease. So on the climbing slides, we're going to talk about the ureters, we're going to talk about the trigony, the urethra, and this is just going to be a good reference slide for you to go back and see what these structures look like, where they are in reference to each other. The ureters. So these are two slender tubes, each about 25 to 30 centimeters or 10 to 12 inches long, and 6 millimeters or a quarter inch in diameter. Each ureter runs behind the peritoneum from the renal hilum to the posterior aspect of the bladder, which it enters at a slight angle. The superior end of each ureter is continuous with the renal pelvis, and its mucosal lining is continuous with the mucosal lining of the renal pelvis and the bladder inferiorly. The ureters carry urine from the kidneys to the bladder. Although it might appear that gravity could help drain urine to the bladder, it would not transport urine while a person is lying down. But urine reaches the bladder even when you're standing on your head because the ureters do play an active role in urine transport. Smooth muscle layers in their walls contract to propel urine by peristalsis, which you should recognize that word. Once urine has entered the bladder, it's prevented from backflowing into the ureters by small valve-like folds of the bladder mucosa called that cover the ureter openings. So we don't get any backflow into the kidneys. The homeostatic imbalance here, you can see kind of in this small photo on the right, is renal calculi. So when urine becomes extremely concentrated, solutes such as uric acid salts form crystals that precipitate in the renal pelvis. These crystals are called renal calculi, or more commonly known as kidney stones. So this is associated with excruciating pain that radiates to the flank, lateral, posterior lower back, occurs when the ureter wall closes in on a sharp calculi that they are being eased through the ureter via peristalsis, or when the calculi become wedged in the ureter. Frequent bacterial infections of the urinary tract, urinary retention, alkaline urine, all favor calculi formation. Surgery is one treatment option, but a non-invasive procedure called lithotripsy uses ultrasound waves to shadow the calculi if possible. The pulverized remnants of the calculi are then painlessly eliminated in the urine. So you can see here, this is a male in the urogram after he was injected with 80 mLs of iodized contrast medium, and that just allows us to see the whole flow here. The contrast medium in yellow travels from the kidneys toward the bladder, and the presence of a kidney stone is highlighted in red. Urinary bladder. It's a smooth collapsible muscular sac that stores urine temporarily. It is located retroperitoneally in the pelvis, just posterior to the pubic symphysis. And you can kind of see that in the image here on the right. A scan of the interior of the bladder reveals 3 openings: 2 ureter openings called ureteral orifices, and the single opening of the urethra, the internal urethral orifice, which drains the bladder. The smooth triangular region of the bladder base outlined by these 3 openings is called the trigone. I think I pronounced it trigony on the last a couple slides ago, but it's the trigone. The trigone is important clinically because infections tend to persist in this region. In males, the prostate, which is part of the male reproductive system, surrounds the neck of the bladder where it empties into the urethra. The bladder wall contains 3 layers of smooth muscle. Collectively, these are called the detrusor muscle, and its mucosa is a special type of epithelium called transitional epithelium, which we learned about in chapter 3. Both of these structural features make the bladder uniquely suited for its function of urine storage. When the bladder is empty, it is collapsed. It's 5 to 7.5 centimeters, so 2 to 3 inches long at most, and its walls are thick and thrown into folds. As urine accumulates, the bladder expands and rises superiorly in the abdominal cavity. Its muscular wall stretches, the transitional epithelial layer thins, and increasing the volume and allowing the bladder to store more urine without substantially increasing its internal pressure. A moderately full bladder is about 12.5 centimeters, which is 5 inches long, and holds about 500 mLs of urine, but it is capable of holding more than twice that amount. When the bladder is really distended or stretched by urine, it becomes firm and pear-shaped and may be felt just above the pubic symphysis, which I'm sure you've all felt your full bladder if you really have to go to the bathroom. Urine is formed continuously by the kidneys, but it is stored in the bladder until its release is convenient. The urethra. It's a thin-walled tube that carries urine by peristalsis from the bladder to the outside of the body. At the bladder urethral junction, a thickening of smooth muscle forms the internal urethral sphincter, which is an involuntary sphincter that keeps the urethra closed when urine is not being passed. A second sphincter, the external urethral sphincter, is formed by skeletal muscle as the urethra passes through the pelvic floor. As we know, skeletal muscle is voluntary, so this is a voluntarily controlled sphincter. The length and relative function of the urethra differ between the 2 genders. In men, the urethra is approximately 20 centimeters or 8 inches long and has 3 named regions: the prostatic, membranous, and spongy urethrae. The urethra opens at the tip of the penis after traveling down its length and has a double function in males. It carries both urine and sperm from the body, but never at the same time. In males, the urethra is part of both the urinary and reproductive system. In women, the urethra is considerably shorter, only about 1.5 inches long. An external orifice or opening lies anteriorly to the vaginal opening. Its only function is to conduct urine from the bladder to the body exterior. And some of the homeostatic imbalances here. So The female urinary orifice is close to the anal opening, so improper toileting habits, like wiping back to front rather than from front to back, can carry that fecal matter to the urethra, and because the mucosa of the urethra is continuous with the rest of the urinary tract organs, inflammation of the urethra or urethritis can easily ascend the tract to cause bladder inflammation, cystitis, or even kidney inflammation, pyelonephritis or pyelitis. Symptoms of urinary tract infection include dysuria, which is painful urination, urinary urgency and frequency, fever, and sometimes cloudy or blood-tinged urine. When the kidneys are involved, back pain and a severe headache are common. Micturition, so also known as voiding, is the act of emptying the bladder. As noted, there are those two sphincters or valves, the internal urethral sphincter, which is more superiorly located, and the external urethral sphincter, more inferiorly located. Sorry, I cannot speak today. Which control the flow of urine from the bladder. Ordinarily, the bladder continues to collect urine until it's about at a capacity about 200 cc's or 200 mLs. At this point, stretching of the bladder will activate stretch receptors. Impulse is transmitted to the sacral region of the spinal cord and then back to the bladder via the pelvic splanchnic nerves, cause the bladder to go into reflex contractions. As the contractions become stronger, stored urine is forced past that first sphincter, the internal urethral sphincter, again, smooth muscle, so involuntary, into the upper part of the urethra. The person will then feel the urge to void. Because the lower external sphincter is a skeletal muscle and controlled voluntarily, we can choose to keep it closed and postpone that bladder emptying. However, if it is convenient, the external sphincter can be relaxed so that urine is flushed from the body. So when you choose to go to the bathroom. When a person chooses not to void, the reflex contractions of the bladder stop within a minute or so, and the urine collection just continues. After 200 to 300 mLs more have been collected, that micturition reflex will occur again. Eventually, micturition occurs whether the person wills it or not. So if you wait too long, you're gonna go. So incontinence occurs when a person is unable to voluntarily control that external sphincter. It's normal in children 2 years old or younger because they've not yet gained control over their voluntary sphincter. It may also occur in older children who sleep so soundly that they are not awakened by the stimulus. However, after the toddler years, incontinence is usually a result of emotional problems, pressure as in pregnancy, or nervous system problems, stroke, or spinal cord injury. And there are many different types of incontinence, but we won't go into that in this class. Urinary retention is essentially the opposite of incontinence. In this condition, the bladder is unable to expel its contained urine. There are various causes for urinary retention. It often occurs after surgery, in which general anesthesia was given, because it takes a little time for the smooth muscles to regain their activity. Another cause of urinary retention occurring primarily in older men is enlargement or hyperplasia of the prostate. Because of its location, as the prostate gland enlarges, it narrows the urethra, making voiding very difficult. When urinary retention is prolonged, a slender flexible drainage tube called a catheter must be inserted through the urethra to drain the urine and prevent bladder trauma from excessive stretching. Body fluids and fluid compartments. So if you're a healthy young adult, water probably accounts for half or more of your body weight. So 50% in women and about 60% in men, and the differences reflect the fact that women have relatively less muscle and a larger amount of body fat. Of all body tissues, fat contains the least water. Babies with little fat and low bone mass are about 75% water. This accounts for their dewy baby skin, like that of a freshly picked peach. After infancy, total body water content declines through life, finally accounting for only 45% of body mass in old age. Water is a universal solvent within which all solutes, including very important electrolytes, are dissolved. So water occupies three main locations within the body, referred to as fluid compartments. About 2/3 of body fluid, the intracellular fluid, is contained within living cells. The remainder, called extracellular fluid, includes all body fluids located outside the cells. includes plasma, interstitial fluid between cells, lymph, and transcellular fluid, which is in chambers lined with epithelium, which includes cerebrospinal fluid and serous fluids, the humors of the eyes, and others. And you can see that kind of represented in the chart here by percentage of total body water. As plasma circulates throughout the body delivering substances, it serves as the highway that links the external and internal environment. So exchanges occur almost continuously in the lungs, in the GI tract, and in the kidneys. Although these exchanges alter plasma composition and volume, adjustments in the other two fluid compartments follow quickly so that balance is restored. That's what you're seeing here on this chart is nutrients and waste are exchanged between the intracellular fluid and the plasma through the interstitial fluid, excuse me. Blood plasma transports nutrients and waste between the cells and external environment of the body. Regulation of water intake and output. So if the body is to remain properly hydrated, it cannot lose more water than it takes in. Most water intake comes from fluids and foods that we ingest in our diet. However, a small amount, about 10%, is produced during cellular metabolism. The thirst mechanism is the driving force for water intake. So an increase in plasma solute content of only 2 to 3% will excite highly sensitive cells in the hypothalamus called osmoreceptors. Osmo meaning water, which in turn activate the hypothalamic thirst center. The mouth also becomes dry because salivary glands obtain the water they require for blood. When less fluid leaves the bloodstream, less saliva is produced, reinforcing this thirst response. The same response results from a decline in blood volume or pressure, although this is a less potent stimulus. And we'll talk, actually it's right here on this chart. You can see in the first image, we're looking at major sources of body water and routes of water loss from the body. When intake and output are in balance, the body is adequately hydrated. So if your average intake per day is equal to your average output, we're all gravy, baby. And then the other figure on the right is the thirst mechanism for regulating water intake. So as we start at the top, those increased plasma solutes will lead to osmoreceptors in the hypothalamus being triggered, a decrease in saliva causing dry mouth, which will cause a thirst response. Makes us want to drink. So water moistens the throat, stretches the stomach, intestines, water absorbed in the GI tract, and those plasma solutes will become lower in the plasma. It is noted that water does leave the body via several routes. So some water vaporizes out of the lungs, some is lost in perspiration, so sweating, some leaves the body in stool. So the job of the kidneys is like that of a juggler. If large amounts of water are lost in other ways, the kidneys compensate by producing less urine to conserve body water. So this is the same reason why if you're out in a hot place hiking, you're sweating a lot, you're not needing to pee as often. It's helping to regulate that fluid volume. In addition to regulating fluid volume, kidneys ensure the proper concentrations of various electrolytes in both the intracellular and extracellular fluids. We'll talk about that a little more and what things are involved in regulating the electrolyte composition of body fluids on the next slide. So the reabsorption of water and electrolytes by the kidneys is regulated primarily by hormones. When blood volume drops for any reason, for example, a result of hemorrhage, excessive water loss through sweating, or diarrhea, arterial blood pressure drops, which in turn decreases the amount of filtrate formed by the kidneys. In addition, the hypothalamic osmoreceptors react to a change in blood composition by becoming more active. The result is the nerve impulses are sent to the posterior pituitary, which then releases antidiuretic hormone, which should sound familiar to you. As you might guess, this hormone prevents excessive water loss in the urine, antidiuresis. Antidiuretic hormone travels in the blood to its main target, the kidney's collecting ducts, where it causes the duct cells to reabsorb more water. As more water is returned to the bloodstream, blood volume and blood pressure increase to normal levels, and only a small amount of concentrated urine is formed. ADH is released more or less continuously unless the solute concentration of the blood drops too low. And when this happens, the osmoreceptors become quote-unquote quiet and excess water is allowed to leave the body in urine. So in this chart here, it can be pretty daunting, but if you just follow the lines, this is just showing mechanisms regulating sodium, ion, and water balance to help maintain blood pressure, starting at the top with a fall in systemic blood pressure or volume. Blood solute levels, fluid volume, and blood pressure are all interrelated. Note that the intersection of blood pressure homeostasis and the thirst mechanisms regulating water intake at the hypothalamic osmoreceptors. This helps increase fluid volume and therefore blood volume, which directly influences blood pressure. Maintaining electrolyte balance. So very small changes in electrolyte concentrations in various fluid compartments cause water to move from one compartment to another. This movement does not only alters blood volume and blood pressure, but also can severely impair the activity of irritable cells such as nerve and muscle cells. For example, when the level of potassium in the extracellular fluid is low, muscle cells may not be able to repolarize properly, which can lead to things like muscle cramps. Besides antidiuretic hormone, aldosterone, which should also sound familiar to you, is a second hormone that helps to regulate blood composition and blood volume by acting on the kidney. Aldosterone is the major factor regulating sodium ion content in the ECF, and in the process helps regulate the concentration of other ions like potassium ions, chloride ions, magnesium ions as well. Sodium ions are the electrolytes most responsible for osmotic water flow. Water follows salt. When too few sodium ions are in the blood, water will leave the blood and enter tissues, causing edema. If serious, this situation can cause circulatory system to shut down. Regardless of whether aldosterone is present or not, about 80% of the sodium ions in the filtrate are reabsorbed in the proximal convoluted tubules of the kidneys. When the aldosterone concentration is high, most of the remaining sodium ions are actively reabsorbed in the distal convoluted tubules and are in the collecting ducts. Generally speaking, for each sodium ion reabsorbed, a chloride ion follows and a potassium ion is secreted into the filtrate. Thus, as sodium ion content of the blood increases, the potassium ion concentration decreases, bringing these two ions back into normal balance in the blood. Still, another effect of aldosterone is to increase water reabsorption by the tubule cells. As sodium ions are reclaimed, water follows it passively back into the blood. Recall, aldosterone is produced by the adrenal cortex. Although a rising potassium ion level or a falling sodium ion level in the ECF directly stimulates the adrenal cells to release aldosterone, the most important trigger for aldosterone release is the renin-angiotensin mechanism, mediated by the juxtaglomerular JG apparatus of the renal tubules. The JG apparatus consists of a complex of modified smooth muscles called JG cells in the efferent arteriole plus some modified epithelial cells forming part of the distal convoluted tubule. The naming of this cell cluster reflects its location close to the glomerulus. When the cells of the JG apparatus are stimulated by low blood pressure in the efferent arteriole or changes in solute content of the filtrate, they respond by releasing the enzyme renin into the blood. Renin initiates the series of reactions that produce angiotensin II. Angiotensin II in turn acts directly on the blood vessels to cause vasoconstriction, leading to an increase in peripheral resistance, and on adrenocortical cells to promote aldosterone release. As a result, blood volume and blood pressure will increase, and the renin-angiotensin mechanism is extremely important in regulating blood pressure. When blood pressure drops, baroreceptors in large blood vessels are also excited. These baroreceptors alert sympathetic nervous system centers of the brain to cause vasoconstriction via the release of epinephrine and norepinephrine. However, this neural mechanism's major focus is blood pressure regulation, not water or electrolyte balance. And the homeostatic imbalance here is Addison's disease, also something we learned about in the endocrine chapter. But people with Addison's disease or hypoaldosteronism have polyuria, which means they excrete huge volumes of urine and so lose tremendous amounts of salt and water in the urine. So as long as adequate amounts of salt and fluids are ingested, people with this condition can avoid problems, but they are constantly teetering on the brink of dehydration. Maintaining acid-base balance in the blood. So for cells of the body to function properly, blood pH must be maintained between 7.35 and 7.45. So this is a pretty narrow range. Whenever the pH of arterial blood rises above 7.45, a person is said to have alkalosis, and a drop in arterial pH below 7.35 is acidosis. Because the pH of 7.0 is neutral, any pH between 7.0 and 7.35 is not acidic. Chemically speaking. However, it represents a lower than optimal pH for the functioning of most body cells. Therefore, any arterial pH in this range is called physiological acidosis. There are a couple ways that we maintain this acid-base balance. So we have blood buffers. So chemical buffers are systems of one or two molecules that act to prevent dramatic changes in the hydrogen ion concentration when acids and bases are added. They do this by binding to hydrogen ions whenever the pH drops and by releasing hydrogen ions whenever the pH rises. The chemical buffers act within a fraction of a second so that they are the first line of defense in resisting pH change. Also recall that bases are proton or hydrogen ion acceptors. Strong bases such as hydroxides dissociate easily in water and quickly tie up hydrogen ions, but weak bases such as bicarbonate ion and ammonia are slower than hydrogen ions, slower to accept hydrogen ions. As pH drops, the weak bases become stronger and begin to tie up more hydrogen ions. Thus, like weak acids, they are valuable members of the chemical buffer system. The three major chemical buffer systems of the body are the bicarbonate, phosphate, and protein buffer systems, each of which helps to maintain the pH in one or more of the fluid compartments. They all work together, and anything that causes a shift in hydrogen ion concentration in one compartment also changes in the others. Thus, any abnormal pH level is resisted by an entire buffering system. Because all three systems operate in a similar way, we'll examine, in the book it examines just one, the bicarbonate buffer system. I'm not going to test you on this, but you can go into your book and read about it. Then we have respiratory mechanisms. The respiratory system eliminates carbon dioxide from the blood while it loads oxygen into the blood. When carbon dioxide enters the blood from the tissue cells, most of it enters the red blood cells where it's converted to bicarbonate ion for transport in the plasma, as shown in the equation that is in the book. Again, not going to test you on it. In healthy people, carbon dioxide is expelled from the lungs at the same rate as it is formed in the tissues. The hydrogen ion released when carbon dioxide is loaded into the blood is not allowed to accumulate because it is tied to water when carbon dioxide is unloaded in the lungs. So under normal conditions, the hydrogen ions produced by carbon dioxide transport has essentially no effect on blood pH. However, when carbon dioxide accumulates in the blood, for example, during any kind of restricted breathing, or more hydrogen ions are released by the blood by metabolic processes, the chemoreceptors in the respiratory control centers of the brain or in the peripheral blood vessels are activated. As a result, breathing rate and depth increase, and the excess hydrogen ions are blown off as more CO2 is removed from the blood. On the other side of that, when blood pH begins to rise, alkalosis, the respiratory center is depressed. Consequently, the respiratory rate and depth fall, allowing carbon dioxide and therefore hydrogen ions to accumulate in the blood. Again, blood pH is restored to the normal range. And then renal mechanisms. So the most important means by which the kidney maintains acid-base balance of the blood are by excreting bicarbonate ions and reabsorbing or generating new bicarbonate ions. Renal mechanisms undertake adjustments. So as blood pH rises, bicarbonate ions are excreted and hydrogen ions are retained by the tubular cells. Conversely, when the blood pH falls, bicarbonate ions are reabsorbed and generated, and hydrogen ions are excreted. Urine pH varies from 4.5 to 8, which reflects the ability of the renal tubules to excrete basic or acidic ions to maintain blood pH homeostasis. Developmental aspects of the urinary system. So when you trace the embryonic development of the kidneys, it almost seems as though they can't make up their mind about whether to come or go. The first tubule system forms and then begins to degenerate as a second lower set appears. The second set in turn degenerates as a third set makes its appearance, and this third set is the one that develops into functional kidneys. These begin excreting urine by the third month of fetal life. However, the fetal kidneys do not work nearly as hard as they will after birth because exchanges with the mother's blood through the placenta allow her system to clear many of the undesirable substances in the fetal blood. Because the bladder is very small and the kidneys are unable to concentrate urine for the first 2 months, a newborn baby voids 5 to 40 times per day, dependent on their fluid intake, which seems kind of crazy. By 2 months of age, the infant is voiding approximately 400 mLs a day, and the amount steadily increases until adolescence when adult urine output is achieved, which is about 1,500 milliliters a day. Control of the voluntary urethral sphincter coincides with nervous system development. So by 15 months, most toddlers are aware when they are voided. By 18 months, they can hold their urine in their bladder for about 2 hours, which is the first sign that it's time to start potty training. A child usually achieves daytime control well before nighttime control, which is usually not complete until the age of 4. During childhood and through late middle age, most urinary system problems are infectious or inflammatory. Many types of bacteria may invade the urinary tract to cause urethritis, cystitis, or pyelonephritis. E. coli are normal residents of the digestive tract and generally cause no problems there, but they act as pathogens in the sterile environment of the urinary tract and account for 80% of urinary tract infections. Bacteria and viruses responsible for STIs or sexually transmitted infections may also invade and cause inflammation in the urinary tract, which leads to the clogging of some of its ducts. As we age, our kidney size and function progressively decline, and by age 70, the rate of filtrate formation is only about half of that of a middle-aged adult, and this is believed to result from impaired renal circulation due to atherosclerosis. In addition to a decrease in number of functional nephrons, the tubule cells become less efficient in their ability to concentrate urine. Another consequence of aging is bladder shrinkage and loss of bladder tone, causing many elderly individuals to experience urgency and frequency. Nocturia, the need to get up during the night to urinate, plagues almost 2/3 of this population. In many, incontinence is the final outcome of the aging process. So we start with incontinence and end with incontinence. Urinary retention is another common problem, most often the result of hypertrophy of the prostate gland in males. Other adults can avoid some of the problems of incontinence and retention by maintaining a regular regimen of activity that helps the body as a whole in optimum condition and keeps it in optimum condition and promotes alertness to those elimination signals. Some of the homeostatic imbalances. Adult polycystic kidney disease is a degenerative condition that appears to run in families. One or both kidneys enlarge and sometimes the size of a football, and they have many blister-like sacs or cysts containing urine. These cysts interfere with renal function by obstructing but initially not stopping urine drainage. Currently, little can be done for this condition except to prevent further kidney damage by avoiding infection. Renal failure is the eventual outcome, but kidney transplants improve chances of survival. In the rarer infantile form of this disease, the kidney has blind pouches into which the filtrate flows, totally blocking drainage. This disease progresses rapidly, unfortunately resulting in death by age 2 years. Hypospadias is a condition found in male babies only. It occurs when the urethral orifice is located on the ventral surface of the penis. Corrective surgery is generally done when the child is around 12 months old. And then glomerulonephritis. So childhood streptococcal infections such as strep throat and scarlet fever may cause inflammatory damage to the kidneys if the original infections are not treated promptly and properly. A common sequel to untreated childhood strep infections is glomerulonephritis, in which the glomerular filters become clogged with antigen-antibody complexes resulting from that strep infection. Let's take a closer look at renal failure and the artificial kidney. So more than 1 out of every 7 Americans, or about 15% of American adults over the age of 18, has some degree of kidney dysfunction. 90% of adults with chronic kidney disease, or CKD, are unaware of their status. And the main risk factors for CKD are diabetes and hypertension. It's more common in people over the age of 65, more common in women, and 3.5 times more common in African Americans than in Caucasians. Patients who advance to end-stage kidney disease need dialysis or a kidney transplant in order to survive. More than half these patients, again, have diabetes or hypertension. Other warning signs may include frequent urination, painful urination, swollen hands or feet. Urinalysis can detect proteinuria. It's a sensitive and early marker for kidney damage, and a simpler blood test can determine the creatinine level, which can be used to estimate the rate of blood filtration. And what you're looking at here in this image is a renal patient undergoing hemodialysis. High blood pressure impairs kidney function by damaging renal blood vessels and reducing circulation to the organs. Even as hypertension battered kidneys push blood pressure upward. In renal failure, filtrate formation decreases significantly or stops completely. Because toxic wastes accumulate quickly in the blood, hemodialysis uses an artificial kidney apparatus called a dialyzer to cleanse the blood. The patient's blood is passed through tubing that is semi-permeable, meaning only select substances can diffuse through it, and the tubing is immersed in a solution called dialysate. Dialysate is a low-pressure fluid that allows substances to be exchanged with the blood via diffusion. Nitrogenous waste and potassium ions diffuse out of the blood, and electrolytes such as sodium ions and bicarbonate ions diffuse into the blood. As the concentration of waste in the dialysate increases, the dialysate is replaced so the waste can continue to diffuse out of the blood. Typically, it's done 3 times per week and takes about 3 to 5 hours on average. But this will be dependent on patient size and kidney function. It can take up to 8 hours. So you can see how this could be very disruptive to somebody. If 3 days a week, you have to commit 8 hours to just sitting there receiving this treatment. The year 2020 saw a drastic increase in the number of patients needing dialysis as a result of COVID-19. Although it is not yet understood how COVID leads to renal failure, early data suggests 14 to 40% of COVID-19 patients develop kidney failure and require dialysis as a life-saving measure. Risks of hemodialysis include infection, thrombosis, and hemorrhage due to blood thinners required to prevent clotting in the machine itself. When renal damage is irreversible, as in a chronic renal failure patient, continued dialysis and kidney transplant are the only options for treatment. If transplant is done, except in cases where the donor is an identical twin, recipients must take immunosuppressive drugs to prevent rejection of the donated organ. So again, the essentials here are the most important risk factors are for CKD are diabetes and hypertension. It's more common in people over the age of 65, in women, and in African Americans. Tests for things like proteinuria and creatinine are simple to perform and can help identify disease early. And dialysis can remove toxins from the blood in patients whose kidneys no longer function sufficiently. And per usual, any questions, comments, concerns, please feel free to let me know.